So let's talk about if topography is an essential part of myopia management or myopia control. If we talk first about glaucoma. Glaucoma is a degenerative condition that develops typically in over 40s. It can lead to severe vision loss. It has a prevalence of around about 1.43% in patients under 64. And instrumentation is required to detect changes before the patients are aware of them. And treatment either prevents or reduces the impact of the condition on the patient. And I think if we were to be asked the question, if it was neglectful to not screen under 64-year-old patients for glaucoma, I think the answer to that would be yes, it's a primary responsibility for optometrists. If we now compare that to keratoconus, well, keratoconus tends to develop in childhood up to the 40s. It will also lead to severe vision loss. It has a prevalence of around about 1.38%. Instrumentation can detect the condition before patients are aware they've got it. And also now with corneal cross-linking, treatment can prevent or reduce the impact of that. So let's look at a patient example. So here we've got the prescription and the VAs for a patient over a sort of 10-year period, starting at 2006, going through to 2016. And you can see that the prescription is a low prescription. There's no sign really of any indication of prescription until we get to 2012. And the visual acuity is 6.6 minus and vision is pretty good. In 2012, however, we start to see a bit of a myopic prescription come in. And then by 2014, we can see that the prescription then starts to indicate a more significant change. So we would probably have prescribed glasses around about this stage. Patient is starting to get or be improved from 6.12 to 6.6. So that's a significant benefit for the patient. But at this point, we would then start to diagnose, probably keratoconus would start to be recognised. If we compare that to the topography that happened with this patient at the same time, you can see that topography detects the patient's keratoconus at this stage, which is about 6 years prior to the indication that we would pick up with the prescription. If I then introduce the patient's age at this point, you can see that if this is a young patient, if this was picked up now, they would have had cross-linking within about a year probably of diagnosis, which have meant that they would have had sort of 6.9, 6.6 minus VAs throughout the rest of their life because of the cross-linking. What's important now, and to make the comparison to glaucoma, is that patient in the first up to 2012 is asymptomatic. They have no awareness of having this condition. And it's only beyond this point that they come in complaining of symptoms that we then recognise. So in the period of time where the patient is asymptomatic, we need to pick up the condition there with screening, with instrumentation, and that's topography. However, at the point that the patient's in complaining of symptoms and they're saying their vision is poorer, this is when we're at risk of misdiagnosing, and particularly if you look at the 2012 prescription, it's very easy at this stage to misdiagnose this as simple myopia. Have a conversation about myopia control, provide a myopia control correction, and then have that proved wrong effectively the next year where you start to recognise that the keratoconus is there. Topography is really key if there's any prescription change, and if you're going to recommend a product for myopia control, to ensure that you're not misdiagnosing keratoconus as myopia. Of course, topography is a new topic for a lot of people, and you don't have much understanding, and that's one of the kind of good things about topographers is you can see here we've got 4 different plots. They look very different. Well, they are 4 different types of keratoconus effectively. And if you don't understand this, the fact that you have the topographer gives you access to professional services where you can get more information and more learning on how topography works, how to interpret it. And it also improves your clinical record keeping. You can document whether it's imagery, the fit of contact lenses, the progression of a patient. That can all be done with the instrumentation. So to summarise, myopia can be misdiagnosed as keratoconus. And because keratoconus is now treatable with cross-linking, we really need to consider screening for keratoconus as a role for optometrists to provide in practice. So as a minimal clinical practice, we should really be doing topography on any patient under 40 that has any prescription change. That way we would know that the prescription change is not corneal and not keratoconus. And I think it would be good clinical practice to bring in topography into screening all patients, particularly younger patients, so that keratoconus can be detected and effectively eradicated because of corneal cross-linking. Particularly important at the point that we're prescribing glasses or first contact lenses for patients. Because of myopia, we should have topography at that point to establish that it's not keratoconus. There is a bit of a buzz just now around axial length, but of course axial length correlates really well to the myopic change, the prescription change. So axial length is probably beneficial within the context of myopia control, but if we're seeing a prescription change, whether that be with spectacle prescription, whether it's with soft contact lens prescription, whether it's with base curve, with ortho-K, they all correlate well to axial length changes that will also be going on. So I think axial length, yes, it's a beneficial thing, but it certainly comes after topography, which has the advantages of screening for keratoconus and avoiding misdiagnosis. If you enjoyed this video, watch the other videos in the series, and thanks for watching.